Hello, this is Will Mercer with the Office of the Medical Director. We're going to be going over pelvic trauma and pelvic binders today. Key objectives are differentiating between hip and pelvic fractures, and then learning when and how to apply the pelvic binder. Why do we care? A pelvic fracture, walking in the door, pun intended, has a 16% overall mortality. If they're hemodynamically unstable, that jumps to 27%. And then the pelvis is a very rigid structure. Any force that was applied to that likely caused other injuries as well. But 25% of those polytraumas died just from the pelvic hemorrhage. Now, in the MedStar system between January 1 and May 31st of this year, we had 33 pelvic binders applied. Of those, 70% were applied inappropriately. What do we mean by that? They were applied on hip or femur fractures, on hip dislocations, or precautionary in patients that didn't even need them. So we need to go back and do a little bit of A&P. So here's the pelvis. It is made of the sacrum, the ilium, pubis, ischium, and coccyx. It is a very rigid structure. And then on the pelvis, you have the hip. So the hip is going to be a region. The pelvis is an actual bone. Sitting in this hip socket here, you've got the head of the femur. It can get dislocated. 90% go posterior, which will present inwardly rotated but not shortened. And then this is the head of the femur, where you can have multiple different fracture sites. So again, the pelvis is a very rigid structure. It is also a circle, and it is very vascular. So you see the huge amount of blood supply that is moving through this ring. But if you look over here at the hip, you'll notice that there's not a lot of vasculature around here. So any force that was applied to this pelvic ring that could fracture it likely caused bleeding as well. And our primary concern is going to be venous bleeding. So 80% of it is going to be due to veins. Arteries can actually clamp down and prevent excessive bleeding. Veins don't have that capacity. And that's a key point that I want y'all to hold on to as we progress through this presentation. Pelvic fractures are categorized into either stable, which is still weight bearing, although I'm not going to drive my truck over that, and then unstable, which is a complete failure of the structure. And this is what the unstable pelvic fractures look like. So the anterior posterior, the open book, presents with the classic frog leg presentation. Then you've got lateral compression injuries where it is pushed or folded over, and then vertical shear where it is actually pushed backwards. The MOIs for this are very significant. So lateral compression, an example would be a side impact, MVC. You notice the amount of intrusion into this vehicle. Anterior posterior compression, you've got frontal impacts, autopeds, motorcycle accidents, and then vertical shear, going to be your fallers or your jumpers. They'll actually try to land with one foot first, and that's enough force to actually shear the pelvis. And then your stable pelvic fractures. So looking at these pictures compared to the unstable pelvic fractures, here the ring has been compromised. In the stable pelvic fractures, the ring is still intact. But again, there was significant force applied to the structure, and there is going to likely be some internal bleeding. And then we have the acetabulum. That's actually the hip, just because I like to say the word acetabulum. So we don't have a way to really physically view these fractures. So how can we predict what we are dealing with? Well, we got a video to kind of give you an idea.
Oh my God, look what you just did to my car. Hello, lady, car stopped ahead of you. Maybe if you'd stop cramming your face full of ice cream, you'd notice these things.
Is everybody here okay?
Yeah, I just got rear-ended, that's all.
Does anybody need an ambulance?
Well, I got a little whiplash, but I think I'm okay.
All right, we need to keep traffic flowing here, so go ahead and get back in your cars, and we'll get ready to move them to the shoulder.
All right. Holy crap, Johnson, come here. Did you see this mechanism of injury? Why isn't she C-spined yet? I want those batteries cut, and I want C-spines here now. Much better. All right, McMahon. I know this seems kind of silly, but why don't you go ahead and cut open that other car and cut that battery too, just in case. Oh, ma'am, if you go and lay down for me, I'm gonna put this brace down on your neck.
Look, my neck's just a little sore. I don't need any of that.
Ma'am, with all due respect, just look at that mechanism of injury.
Yeah, my car got hit.
Do you realize that tomorrow morning you could wake up and be a paraplegic? Is that what you want? Ma'am, come here. Does this hurt?
Ow, yes, that hurt. Ah!
'Cause that shouldn't hurt, ma'am. That should not hurt. Something could be wrong with your neck, okay? So you should probably let us take you to the hospital.
Okay, what do we got here? Holy, look at that mechanism of injury. Why isn't she C-spined yet?
Well, she just doesn't think that anything's wrong with her.
Well, did you even try the poke the spine test?
Twice. I guess she just doesn't understand the scientificness of that test.
Look, guys, I really feel like I'm okay. You're starting to scare me.
Ma'am, you should be scared. You see this? I didn't spend 22 weeks at EMT school for nothing.
All right, go ahead and lay back and relax, and we'll get you wheeled on over to the ambulance, okay?
I think this is a little too serious to be hanging out in traffic for.
Yep, those rubberneckers sure make a mess of things. Dispatch 20 copies. Air ambulance landing on the freeway, and all traffic is already stopped.
MRE Air 1 on approach. Oh, look at that mechanism of injury. I hope they C-spine her.
A helicopter? Really? How much is this gonna cost?
Let me ask you this. Wouldn't you say that your life is worth a mere $17,000?
17,000?
Shh. No thanks is necessary, ma'am. Just doing my job. Well, at least I won't have to drive very far.
So how can we predict what we're dealing with? Mechanism of injury is going to be your key piece of information in determining if this patient has a pelvic fracture or not. So mechanism of injury is number one, then history, and then number three is pain and or tenderness. So we're looking at high forces applied to the body, major accidents, autopeds, high falls. 75% of these patients have other associated injuries, and they're usually hemodynamically unstable. This is going to be in contrast to the ground level fall granny. Usually don't have any other associated injuries, and they're usually hemodynamically stable, and if they are unstable, it's likely caused by something else. A key exam that you can use is palpating the pelvic region. You can have pelvic pain or tenderness is going to be the most reliable finding for predicting the pelvic fracture. If they don't have any pain, it virtually excludes them from having any type of unstable pelvic fracture. Some of us were taught before to rock the pelvis, to push, pull, and wiggle. We don't do that anymore. It's poorly sensitive. It misses 75% of these pelvic fractures, and then it has a lot of risks that are associated with it as well. So you can actually displace bone fragments, dislodge, form blood clots. The first blood clot that's formed is usually going to be the strongest, and if you dislodge that, you can cause more internal hemorrhaging, and the body has to try to work to create that blood clot again. So it sucks as a test, and there's a lot of risks for it. We shouldn't be doing it. Instead, again, you're going to be palpating the pelvis. These are your 3 regions of palpation: over the iliac wings, down by the pubic symphysis, and over the sacroiliac region. You can also do a straight leg raise test. If they have a GCS of 15, no leg or spinal cord injury, and they're not on any pain meds, if they lay on their back and they're able to raise their leg off the bed without any degree of pain, then they probably don't have a pelvic fracture. So these next pictures are pretty gross. Going back to those unstable pelvic fractures, you saw all those bone fragments that were out there. Those can sometimes shear the urethra, which will then produce blood from the lower regions. You can also have significant swelling. And then this right here is actually an open pelvic fracture, which has a 50% mortality rate. So we apply the pelvic binder, treat them for pain, give them IV fluids if they're hypotensive, and then they're a great candidate for TXA to help control that internal hemorrhaging. Key points here are the pelvic binder is a hemorrhage control device. It is a tourniquet for the pelvis. So remember, the veins didn't have that ability to shut themselves to prevent the excessive bleeding, so we are going to do that for them. Secondly, it's an orthopedic device, so it helps reduce excessive movement of the pelvis to help control the patient's pain. It is not going to be a packing adjunct. So just because you're placing somebody in a C-collar, you're not going to also place them in a pelvic binder as precautionary. We kind of just went over that. This is your protocol for the pelvic binder: obvious signs of pelvic injury or instability with signs of hemorrhagic shock. This hospital came up with a great algorithm for using the pelvic binder. The key points here are, though, if the patient has a GCS of 15, they don't have any signs of shock, and there's no distracting injuries, they probably don't need a pelvic binder. And then use in blunt traumatic arrest. So remember, we talked about earlier that 25% of our polytraumas die just from pelvic hemorrhage. That's something that we can control. This footage is from the Isle of Man Tourist Trophy race. It's a race in Ireland where they actually shut down all the residential streets, and these guys fly down the road at 200 miles an hour. It's pretty impressive. Also results in some pretty significant wrecks. If you ever want to waste an hour on YouTube, just Google Isle of Man Tourist Trophy, and it'll bring all these up. Again, these are residential streets, so pedestrians can get involved, and then wildlife as well. And then you've also got some very scenic views. So this is Dr. John Hines. He was the medical director for this race. And he had a procedure for any arrest that they went on. First, he would be dispatched to the call. He would ride over there. He would check for a pulse. If the patient didn't have a pulse, he would then remove all the gear. They would manage the airway, dart the chest on both sides, and then apply a pelvic binder. And then you saw those wrecks. They were pretty significant. Those patients are obviously pretty jacked up. They would have to pull every limb to length. And they would do that before they ever started doing CPR. And more oftentimes than not, they were able to get a pulse back by just doing those procedures. They were very proficient at it. They could get it done in less than a minute. And basically what they were doing was controlling the container. So if you think about the pump is the heart, the body is the container, and the blood is the fluid, they're controlling the container. So if it was working for those wrecks, it's probably going to work for anything that we come across as well. So why do we even need to be selective? Well, binders do not help, and in fact, they can be harmful in those hip and femur fractures. So remember, going back to anatomy, there was not a lot of vasculature around the femur head. All you're doing when you apply that pelvic binder is just displacing that bone even more inside the cavity. There is a risk that you could nick one of those veins or arteries and then cause internal bleeding. There's a risk of skin pressure injuries, and then there's something called diagnostic momentum. Essentially what it boils down to is patients taken to the ER with the pelvic binder. Patient only has a hip dislocation. The doctor doesn't know that, but he sees this pelvic binder and says, well, EMS was suspicious enough to apply a pelvic binder. We need to investigate this pretty thoroughly. and we'll do a CT or an MRI for something that only needs an x-ray. Timing of application, so manage your life threats, airway breathing, and then circulation is when you're going to be applying the pelvic binder. Extrications are very dynamic scenes. If you can apply it safely and appropriately, go ahead and do so. If not, just extricate the patient and then apply it. This is going to be skin to binder, so you will have to cut off all the patient's clothes and then apply this binder. Do not log roll these patients. Be very ginger with them. And then you can use it with the scoop stretcher, and it is placed pretty low. So you're going to start at the knees and move up. So this is kind of an example of where you're going to place it over the greater trochanters, pretty much at the pubic symphysis. You want to make sure that the belt is centered. If that's not good enough for you, it's where Justin Bieber likes to keep his pants. This is a two-person job. So you have one person holding traction on that orange strap, and then another person's pulling on this black strap until these prongs pop out. You will secure it down with the Velcro, and it will lock in place. And it is an orthopedic device. It is securing the pelvis to prevent excessive movement, but it's not controlling the legs. So a good idea would be to secure the patient's feet to help prevent excessive movement, to help better control the patient's pain. Also, again, a lot of these patients have other injuries as well, usually maybe a femur fracture. We cannot use our traction splint with this device. Our traction splints actually apply pressure to the pelvis, so they are contraindicated with pelvic fractures. So what's going to happen is you're going to have to pull the limb to length and hold it there till you get to the hospital. Pediatric patients are made of rubber, so if they have a pelvic fracture, you should suspect a very high mechanism of injury. It is okay to use this on pregnant patients. In an MCI situation, it's okay to use a sheet. And then this product fits about 95% of the population. Our take-home points are: we use mechanism of injury to predict the type of fracture. If it's a high force applied to the body, you should have a high suspicion for serious injury. Consider this a hemorrhage control device. Number one, place it early and place it low. We do not play it on low MOIs or on stable patients. We don't rock the patient, we don't rock the pelvis, and we do not log roll these patients. So that's all I have. I hope this was informative for you guys. Take care and have a good day.